Hi, I'm Dr. Adam Brown with Unstable Vitals. I'm an emergency physician by training, and I'm here with my co-host, Dr. Lara Zibners, who's a pediatrician emergency physician as well. We're having a talk here today with Dr. Stefanie Simmons, who's also an emergency physician, but she's a chief medical officer of the Dr. Lorna Breen Foundation. We wanted to record this episode because it coincides with a really important date, and that is a date that highlights physician suicide. Steph, tell us a little bit about what your organization does and why we should have this conversation today.
Thanks, Adam. September 17th is National Physician Suicide Awareness Day. We know that healthcare workers have mental health conditions, that they have suicidal ideation, and that they have real barriers to accessing mental health care. That's changing, and the Dr. Lorna Breen Heroes Foundation is at the forefront of that change. So I'm really looking forward to this conversation.
So I don't know about both of you, but I'm suspecting you went into medicine for the same reason I did, which is to help people. And unfortunately, that journey costs us uncountable numbers of lives every year in physicians who take their own life because of the experiences that they face. We don't know what that number is because of the challenges in identifying that, because of the stigma associated with suicide, particularly mental health and healthcare professionals. So please join us on this special episode. Thank you.
So if you're a physician, clinician, nurse practitioner, allied health, or anyone working in the healthcare space, and you've ever felt like you're drowning in this system that was actually felt in some ways built to burn you out, this episode is something you should listen to. And with our friend here, Dr. Steph Simmons, talking with us on Unstable Vitals, she'll talk to us in a way that will talk about how we can start to heal the healers and fix the system that's broken around them. Thanks so much.
Unstable Vitals is the podcast that takes the pulse of American healthcare, and the prognosis is critical. Doctors Lara and Adam, former ER physicians turned entrepreneurs and business leaders, expose why the system is unraveling before our eyes. But all hope isn't lost. Lara and Adam cut through the noise, spotlighting what's failing, what's actually working, and what it will take to rebuild a system on the verge of collapse. Buckle up. This is the unfiltered, no BS conversation healthcare desperately needs.
Well, hello everyone to another exciting episode of Unstable Vitals. I'm Dr. Adam Brown with my co-host,
Dr. Lara Zibners.
Yes, and we are here today with Dr. Stefanie Simmons. I cannot wait to jump into this conversation with her. But before we do, Laura, how you doing? What's going on?
My kids are driving me nuts. I'm ready for summer to be over.
Sounds like status quo. Steph, how are you doing?
You know, summertime for us is actually, it loosens up a little bit, our schedule. So I've been enjoying going to the gym at 7 a.m. instead of 6 a.m., having that little phase shift of the sleep. And I've got a high school junior applying to college right now, Lara. So
I'm heading out tomorrow to take my
my
daughter on a whirlwind for university. She's heading into 11th grade as well. And she, we live in Europe, so she really wants to come home to the U.S. for university. So we're going to go do a little sample mother-daughter Sephora in the mix kind of trip for the next 5 days.
Well, okay, I can't be one up. My dog Oscar got back from dog camp while we were away at seeing Coldplay in Miami.
Did he get a certificate?
No, they don't get he can't read. He's a little slow.
But I'm in Colorado right now. When I got married here in Colorado, they spent like 15 minutes explaining how you could have your dog witness your marriage certificate and where the paw print exactly needed to go. And I'm like, no, I'm going to have my daughters do it. Like, we don't have a dog. But they were very, very insistent on making sure I understood exactly where the dog print would go.
The question is, could a hamster do it? Because, what is the name of your hamster? Something like...
No, but so there's Donny Osmond and there's Badger, but Hammy Styles, who passed away, the crematorium sent back his ashes with a little card with his little paw print, his dead paw print. And then my daughter looked at it, she's like, that's the saddest thing I've ever seen.
So that's what's been going on in our world, the past few weeks. But, Steph, I wanted to get in to talk with you, and we wanted to bring you on the show because you do something that is so important. And I've had the privilege of just knowing you, gosh, I don't know, so it's probably like 2015, 2016. I can't remember the exact date, but I remember the exact moment I talked with you for the first time. We were walking back from a conference where you had just made a very impactful discussion talk. You were wearing a black leather jacket. You looked like a badass. You are a badass, so it totally fit. And we were walking into Madison Square Garden Station, Penn Station up in New York City, and we just started talking. And there was like an immediate connection. And then, of course, we got to work together. We became workout buddies at Envision when we were both there. We both left around the same time and then had a whole bunch of other things that you will talk about. But Steph, tell us about yourself. We're so glad to have you on.
Oh, it's my pleasure. And let's not forget, Adam, that you were my boss for at least a year in there. So I got to learn a lot from you as well. So I'm thrilled to be here. And so I'm the Chief Medical Officer of the Dr. Lorna Breen Heroes Foundation. And we are a national nonprofit that looks after the mental health and well-being of the healthcare workforce. And we do that by making sure that the healthcare workforce has access to mental health care, but also we're working to help accelerate the pace of adoption and best practices for the operational environment. So not just increasing access to mental health care, but attacking some of those systems level issues that make it hard to work in healthcare.
As you say that, I'm taken back to my fellowship, my trauma surgery rotation, where I was getting ready to do my trauma surgery rotation, and my PDM fellow who had just finished, she came over to prep me, and she described how she had locked herself in the closet and sliced all the scrubs in the closet to bits with scissors. So are you talking about that kind of operational stuff?
So something led her to that point, right? And it was probably not purely personal. It was probably an interaction of what was going on in her life and what was happening in her work. And frankly, not having the time or the space or the energy left over at the end of the workday to process any of it. And so that is what I'm talking about. And there are really well-defined, evidence-informed things that can transform the workplace for healthcare workers. And there are also really well-defined barriers to seeking mental health care that we can address and overcome in the workforce. So that's what we're doing. That's what we're about.
I think the work is so important, because what I've loved about the Dr. Lorna Breen Foundation, you're going to hear us talk about that Dr. Lorna Breen Foundation quite a bit, because the purpose of this podcast is to talk about things that are unstable in healthcare. And you and I know, Steph, Laura, you and I know, we've talked about this, that the healthcare workforce is not well right now. And there are some little glimmers of hope and some things are better, but we've gone through the trauma of COVID. But there was a lot of things that made the healthcare workforce unwell before that. And, you had earlier mentioned that we worked together and, you led our wellness initiatives at Envision. And I think one of the things that I was always just impressed by you and the things you talked about is understanding the antecedents to what's making us unwell. It's not just that, okay, you've got a doctor who's depressed or a doctor that's burnout. Doctor, go get resilience. That's not like, and go to a class on resilience. It's like, I look at that and I'm like, and I remember you and I even having conversations like, it ain't a class. Like that's not the answer. It's fixing the system. So I've got a question for you after kind of like teeing that up. Is the healthcare system, are our providers, our clinicians unwell, and why are they unwell?
It's a great question. And, in 2019, so let's take a way back trip here to October 2019, we didn't know what was coming. We hadn't gotten the first real glimmers of what 2020 was going to hold. The National Academy of Medicine published a consensus statement on professional well-being for healthcare workers, and they called this an epidemic of burnout. 2019, not knowing that a few months later, the healthcare workforce would be stressed and tested in a way that it hadn't been before in our generation. And so what we've seen as we look at levels of burnout and mental health conditions, and those are separate concepts, right, in healthcare workers, is that things got worse for several years, and we're now just seeing an inflection point back toward those 2019 levels, back toward them, but not yet reaching those levels, which were deemed an epidemic of burnout in 2019. So while I would say there is a glimmer of hope that we're starting to move in the right direction, we are not yet even at what I would say was an admittedly crappy baseline, right, in 2019. And so, yes, individual healthcare workers are struggling, and burnout is not a resilience training deficit condition. It is a workforce demand and resource deficit, right? It's a mismatch between those two things, as well as a lack of the time and resources to process and self-care.
Can we just back up for a sec? Because I think one of the things Adam and I talk about is reminding people that there are human beings on the healthcare. So we have a mental illness rate that is going to be what's existing in the population just at baseline. We are humans. We are people. We are, we have highs and lows. And then on top of that, we're put into environments, particularly in emergency medicine or critical care, things where we see people we've never met them before, and we're thrown into the most stressful environment that person will ever experience. So that combination together, but just for people listening, can you back up and explain why what I just said, but also there's something very unique about healthcare professionals and our ability to seek help for our baseline mental health issues.
Yeah, maybe I'll answer that question with a story, and this is one reason I'm frustrating to my children because I do this a lot. Healthcare workers, when they enter their training, are more resilient than the background population. They wouldn't have gotten there if they weren't, right? And something happens. We are taught and acculturated in a way during our training and our early profession to not take care of ourselves in a way that helps continue that resilience. And I'm not saying that happens to everyone, but it does happen to a significant percentage of us. So here's my story. I was at the end of residency, and I had switched actually from anesthesiology into emergency medicine. So I did the 5-year program for emergency medicine. I had a child during my intern year. So I had a 3-year-old during my 4th year of residency. And I was on a night shift. I had a 3-year-old come in cardiac arrest. Mom said they had been sleeping together on the floor, fell asleep watching movies, and when she woke up in the middle of the night, her daughter wasn't breathing. So she started CPR, she called 911, brought her into the ER. I was her doctor, right? So I'm doing everything, trauma eval, medical eval, and we couldn't get that little girl back. Okay. I spent my time doing what I thought I could do for the person in front of me, which was comforting and consoling the mom, who was the parent who was there. And I went home that night, hugged my daughter when I got home, because it's like, if you are the kid of an ER doc or nurse, sometimes you get woken up when they get home from their shift for a hug, right? And if the story had ended there, it would probably just be one of those stories that we all have,
which is traumatic in and of itself.
Yeah. In and of itself.
Because let me just 1 second. I want to state what you just said about the resilience of doctors. Normal day is dealing with someone in a death and dying situation, sometimes dying situation, like this, like a 3-year-old. That is hard, and we still process it and come back to work the next day or see the next patient in the room next door. That in and of itself is the resilience at work. But then something else happened in your case.
Yeah, so in this case, what happened next was I was called to testify in the murder trial of this little girl, and her mom had killed her. And so the woman I had spent time, right, like comforting and who I had identified with, I was now testifying in her trial, and she was found guilty of overwhelming evidence. It's one of the reasons I can share this story, right, is that it's in the public record. That did something to me. I was so angry. And I was angry, of course, on behalf of that little girl and my patient, right? But I also was angry for myself, because something that I think makes me a really good doctor, which is the ability to connect and to really care about the person in front of me, was damaged in that moment. And at the same time, I was pregnant with my second child, and I developed peripartum and postpartum depression. So it was like a combination of a reactive situation with this case, and then also just biochemistry not being my friend in that moment. It was at the end of residency. I knew I was going to be applying for a job, interviewing for a job, getting state licenses. And in that moment, I knew that I would be asked if I had a diagnosis or a history of a mental health condition, or if I had ever been treated for a mental health condition. And I made the economic decision, with $500,000 of medical school debt, right, behind me, 2 little kids, to not seek care for myself, because I was worried it would impact my employability.
And that is just such a tragedy, and a travesty, because that, I mean, you know, as you know, as we all have done, I've worked in, like, I think 13 states, 25 different hospitals, or 26 hospitals as locums. I've had to fill out those employment credentialing, privileging papers. I've had to file licenses, and almost invariably over the last few decades, the question was asked. It wasn't just in Michigan at your hospital. It was asked, have you sought mental health care? Have you been diagnosed with substance abuse disorder? Have you been diagnosed with depression, anxiety, etc.? Have you been admitted to a hospital? And in some cases, the question was, have you been admitted to a mental health facility? And have you been admitted to a hospital? Not just even from a mental health standpoint, like, you know, I remember putting on, well, I just had my appendix taken out. Like, is this really what they
right?
want to know?
Do you need to know this?
Like, is that important, Mary or John in the credentialing office, to know that I am without appendix? You know, like, I don't.
Appendix. That's a separate toilet you might have to use. Yeah, you have to use a different bathroom.
Right. It's a different area of the hospital we have to work. But what that did to me, and this is, I'm hearing from you, is it was almost a chilling effect of, holy shit, I never, if I ever have depression, I will not disclose it, or either I will just not seek it, because I can't go tell my boss, you know, that I'm taking leave, or I'd have to lie because I'd worry about not getting a license. I mean, this was a real, and has been a real issue and a real thing.
And it's not just you and me, Adam. Surveys had shown that this is one of the largest reasons why healthcare workers don't get help when they need it. So when you want to unpack what has happened with you with a professional to help you process the extraordinary stressors that you experience in the course of providing critical care to the population, you are going to be asked about that, and you're going to be asked about that in the same part of the application where you're asked if you're a felon or a pedophile. And it sends a message about whether having a mental health condition or getting mental health care is safe. Now, that was almost 20 years ago, so I'd love to talk about where we are now, too.
Yeah, of course.
I was going to say, isn't it ironic that people who are being trained as mental health professionals are required to get some sort of therapy themselves to process. But Adam and I did an episode about, don't ever ask an ER doc what the worst thing they've ever seen is, because
Right.
we tucked that somewhere. We don't really want to talk about it. Like I can't
That's
remember.
right.
But
It's
yeah.
true.
And there's a couple ways that, these questions become irrelevant to individuals. One way is everyone is getting mental health care, right? And everyone's answering yes to that question. And frankly, everyone could benefit from at least talking to a counselor or a therapist during medical training and during practice. So, that's one way. In an ideal world, you can get over the importance of that question to people. The second way is to be really transparent and clear about what happens with that information and have it be universally positive, right? We use this information to connect you to resources at our institution. That would require a revamp of some systems and also a degree of transparency and education about processes that doesn't currently exist.
Well, that was something you and I worked on very closely during COVID, because we recognized not only was there an existing burnout and depression and PTSD issue within the physician and clinician workforce, COVID exacerbated that. So you and I worked together to provide those mental health services and resources to all of our clinicians in a way that was transparent, i.e., we're not outing you, like this is a service, you can connect with them. But there is a lot of concern with how do we ensure this information is anonymized? How is this information connecting and getting resources so that clinicians truly feel that this is not going to be used against them? This is when we were providing as a healthcare company resources to someone. And that even the challenge of getting that out there. You had mentioned something I wanted to hit on as well, is that, like you said, 20 years ago, this is what was being asked for on the license. But it was even a year ago in some states, and even 6 months ago, and it's still going on right now. What's Dr. Lorna Breen's foundation doing to try to reverse that stigma, change the system? Tell me more about that.
That's right. So there'd be three ways to get over it. Everybody gets treated. We know exactly what happens with the data, and it's all good. And then the third way is that people ask what they actually want to know, which is, are you currently impaired? Because that's the intention of the question, is, are you impaired in this practice? And so ask that. Or don't ask. So that's the recommendation that we've made, is ask, instead of, have you been diagnosed or treated for a mental health condition or for substance use disorder, ask, are you currently impaired for any reason in your practice? And leave it at that. And so we wanted to make sure the healthcare workforce knew the rules, that they weren't making decisions based on uncertainty and fear. And we also wanted to work towards moving the country in a direction where there was more privacy for mental health care for healthcare workers. And so we created a map and a badge, all right? And the map shows which states' boards have changed their questions to be consistent with best practices, meaning they only ask about current impairment for any reason, and which hospitals and health systems' credentialing applications have been edited to be consistent with best practices. For those states that are consistent, for those hospitals that are consistent, we have the All-In Champions Challenge badge for licensing and credentialing. And when they renew the badge, we ask them to communicate the change to their healthcare workforce. So I'm happy to tell you now that there are 37 medical boards that have received the badge, and growing every month. We're reviewing another state. And that over 1/10 of the hospitals in the country have made this change and been verified by us. So this is a growing change. We're also working with the boards of nursing, dentistry, and pharmacy on this change. And it is happening. So if you fast forwarded 20 years and end of residency Stefanie today was dealing with the same issue, I would be able to tell her Your state licensing application does not ask these questions, and the credentialing application for the place you are applying does not ask you these questions. So that is one of the changes that's being made by the foundation to address this issue.
That's amazing. I think we've kind of jumped ahead and forgotten to mention what the Dr. Lorna Breen Foundation is and where this comes from, because that's extraordinary change. But can you just take us back a bit for those who don't know who Dr. Lorna Breen was and
Sure.
story?
Sure. So Lorna was an emergency medicine physician practicing in Manhattan. She had always wanted to be an emergency medicine doc. I think the three of us can probably resonate with that. And was practicing really at the peak of her game. She was the EM department chair at her hospital, and came back from family vacation to care for patients in the first wave of the pandemic. Cared for patients 16 hours a day, but also took care of her team, right? Mm-hmm. So there was a double caregiving role here, and became exhausted, ultimately got COVID. First wave COVID, no vaccine, got pretty sick with it, but came back to work 24 hours after her fever broke, right? And went right back into the trenches caring for patients. She became exhausted, physically exhausted, emotionally exhausted, intellectually exhausted, and really couldn't get out of her apartment. So her family and her friends worked together to drive her out of New York. If you remember, there was no airplane travel, right? So to drive her out of New York to her hometown in Charlottesville, Virginia. She was hospitalized, received mental health care treatment. And after she was discharged, she expressed to her family that she was terrified that because she had received mental health care, she was going to lose her ability to practice medicine. Her state license, her hospital credentialing, her standing in the community. And she died by suicide. 12 hours after her death, the New York Times published an article about her and about her death. And what happened next is that first dozens and then hundreds and ultimately thousands of healthcare workers reached out to her family to say, Lorna's not alone. There are healthcare workers who are struggling with their mental health, with burnout, with what's happening in the world right now. But this is a problem that existed way before the pandemic, and there's a great need. And so in that time when they had all of this outreach from healthcare workers, the Dr. Lorna Breen Heroes Foundation was started. And in the next year, we began working on our first ever federal legislation to support the healthcare workforce called the Dr. Lorna Breen Healthcare Provider Protection Act. That was passed in March 18th, 2022. Is currently up for reauthorization. We gathered together national organizations like the AMA, the ANA, the AHA, IHI, like the alphabet soup of healthcare, right? To form the All In Coalition, which was a steering committee and a focus group for our work, and also gathered together individuals across the nation to be our ambassadors, and started to work to accelerate solutions for healthcare workforce well-being. The licensing and credentialing work is part of that, but there are also statewide collaboratives that are working to implement operational change that impacts the healthcare workforce positively.
I think it's what is fascinating about the foundation and the work that you've done. I mean, to get a federal legislation passed within a year and a half of kind of start is a BFD, in Joe Biden's word, a big fucking deal, and of course he signed the legislation. It just shows how committed, the team is at the foundation. You mentioned something while you were saying that, healthcare workers were reaching out to you and say, hey, we've been dealing with this. We are dealing with this. Give us a few statistics. And I know this is something you and I have discussed in the past, that healthcare workers are more likely to die by suicide, have more depression. Tell us more, some of those statistics to kind of frame this out of why this is such a focus for healthcare workers. And then we'll talk about some of the system issues beyond credentialing that are some of the causes. So
the healthcare workforce experiences burnout at a rate that is higher than the background population, right? So burnout rates within healthcare are in the mid 40%. That's high. And if you look at specific subpopulations, emergency medicine, it can be even higher, well above 50%. So there's 3 of us here. There you go.
How many of us are still clinically active?
Yeah, exactly. And most of the time when you talk to a healthcare worker and you ask about burnout, they'll say, which time, right? It's not a yes or no, it's a which time. And people go through cycles within their life. There's also, and Lara, I really appreciated your comment that the background rates of mental health conditions are the same for healthcare workers as they are for humans, because it turns out healthcare workers are human. And so,
really?
right,
No, take that back. Say it again. Take that right
healthcare
back.
workers
We are humans?
are
What?
human.
I'm not. I don't know
Yes.
about you two. I am a mother of 3 with 8 arms.
Yeah,
Yeah.
exactly.
Fine. You're telling me I'm human too. All right.
So if you think about like my med school graduating class was 100 people. That means 20 of those people are going to experience a mental health condition in their life. So multiply that times all of the graduating classes in all of the medical schools across all of the country. And that's a lot of people. Add in those barriers to accessing mental health care, which is that significant chilling effect of the invasive and stigmatizing language on licensing, right? And you have a real setup here. So we still see those baseline rates being about 1 in 5 people for healthcare workers. But because of those barriers and perhaps because of other factors like access to lethal means, exposure to death and dying, isolation, we do see almost a 2 times suicide rate for female physicians than other women. Now, the rate of suicide for male physicians relative to the baseline population is about the same, and it is at a baseline that is high. But the things that you think would be protective, like high socioeconomic status, right, meaningful work, et cetera, are not protective for male physicians.
Before you go further into like what are some of the drivers of burnout and depression, and PTSD even within our healthcare system, define it. Like, let's define what burnout actually means, because we throw around that term a lot. So I'd love for you to opine on, what is the definition of burnout? How is that dissimilar from depression or et cetera? Explain that for us.
So mental health conditions like depression, anxiety, schizophrenia, substance use disorders, right? Those are diagnoses, right? That are in the DSM that are the purview of psychiatry and addiction medicine. Burnout is an occupational phenomenon. It is a syndrome of emotional exhaustion, depersonalization, and reduced efficacy that is tied to your workplace environment. And there may be, and often is, crossover with mental health conditions, either as a predeterminate or a resultant, right, condition there. But you can also have or experience burnout separate from mental health conditions, or have, if there is a mental health condition, it is exactly tied, right, to your experience of burnout as well. And so when we look at the workplace environment, there are things that can be modified in the workplace environment that can impact burnout, that may also impact mental health conditions. Okay, separately, right, there are mental health conditions and there are barriers to accessing care that exist because of institutional stigma and culture. And so, this would be a great time for a Venn diagram. But
I love me a Venn diagram.
I know, right? They're separate. There are overlapping solutions and overlapping predeterminants.
And what are some of those solutions? Because my own experience was, I think people outside of what we were doing didn't understand how big it was to get a thank you note.
Oh gosh, yeah, for sure. So even more important than getting the thank you note is taking a moment to actually read the thank you note and posting it on the bulletin board behind your desk and reading it from time to time, right? Because it's like, check, move on, right? And so taking the time to really let those positive moments in our careers sink in. But what I'm talking about, in addition to the things that individuals can do, is the things that we can do in our work environments and for each other. So we started this conversation talking about how burnout is not a resiliency training deficit, right? And there are things that we need to do to take better care of ourselves in resilience, right? Like prioritizing sleep, getting regular exercising, eating healthy foods to the best of our ability, recognizing that our environments and our schedules make all three of those things difficult, right? Especially, Lara, it sounds like you've got 3 kids, I've got 3 kids too. So like my early career was balancing multiple things that made it hard for me to get the job done in terms of self-care. But it's hard for everybody, it is. Having said that, are there ways that, for instance, in scheduling can be done to recognize people's circadian rhythms so that you're having a circadian advancing schedule instead of zigzagging back and forth from nights to days to afternoons? Is there a way to have healthy food in the environment, right? So instead of it always being pizzas and cookies and pies in the break room, thinking about ways to get in some healthy food. Can you optimize your electronic health record to reduce the administrative burden on the healthcare workforce? People don't think about EHR innovations as a well-being program, but they can be if they're kept people-centered, right?
Yeah.
Do you have a bi-directional feedback mechanism in your hospital, health system, or department where the healthcare workforce can raise their hand and say, when I come to work every day to climb this mountain, this thing is the pebble in my shoe. Please remove the pebble in my shoe and I will climb this mountain for you, right? And so that's Muhammad Ali, by the way, said it's not the mountain ahead that defeats you, it's the pebble in your shoe. So those bi-directional mechanisms become really important as well.
And I think that those last few things that you mentioned are so absolutely critical, because the first few things are like getting more sleep, eating more healthy, and we'll get to the break room. But, you know, those are kind of more things that I need to do to make me healthy. That is a piece of that resilience training, understand what makes me well and unwell. But I think where I certainly see where financial drivers are driving hospitals to, and medical groups, et cetera, and staffing agencies do things that make doctors unwell or make the environment less amenable to wellness, is as margins have started to shrink, and as the both in the hospital level and the medical group level, et cetera, the idea of optimizing staffing and matching it to a spreadsheet or matching it to a flow of patients, you and I, or the three of us, all know that even though this may be the average patient flow, there are times when you get feast or famine. There are going to be, because it's an emergency room. Even though it's pretty predictable, there are moments of unpredictability. It's an emergency. That's why. And so things that then start to exacerbate the environment are really overtaxed, understaffed staffing patterns. Making physicians feel like they have to see the quota of patients and not be able to take care of sitting down and comforting a patient, or spending time with a family member that is confused, and you know that would really help the outcome of the patient. Or feeling that pressure, I have to document every single thing that happened at the kind of expense of spending more time at the bedside. Those kind of moral injuries, I think, start to chip away at, your feeling of being a human and your feeling of like, I want to connect with humans and I want to help humans, but I'm being forced to do superhuman things with limited resources. And I know that was something for me that was very, very stressful. I'd walk out at the end of the day and be like, whew, I didn't harm anybody, I don't think. And I finished the charts. It was like,
Yeah.
I finished the charts. And so that environment though needs to be adjusted. We need to recognize on how we have to have some flexibility and capacity as doctors to be able to meet those emergent moments or those moments to spend time with the patient. So just as an aside there.
When you're talking about Adam and Steph, when you were saying this, what was coming through to me was safety. I was thinking of the things that made me the most stressed out when I was clinical. I worked at a busy hospital in New York City, and I had a one fuck you rule, because I felt like if you were there, your child was probably not doing well and you were stressed out. So you could tell me to fuck off once and I'd be like, okay, that's cool. Second fuck off, I hit the red button on the wall and here comes security. And so, but you're talking about like, I have to document because otherwise I'm not safe from a professional standpoint. I'm worried about my personal safety in the emergency department. I'm worried about the patient's safety because we don't have adequate, like one of our most human like needs is safety and security. And I'm hearing that across everything we're talking about is this fear for my job, fear for my reputation, fear for my own like self.
Mm-hmm.
Yeah, I mean, physical safety, psychological safety, ego
Financial?
integrity, like in the, financial safety, all of those things. And, the work demand resource within the shift of how you are able to allocate your time is one thing, but then also across shifts. So do we have Slack built in for human events like PTO or family leaves or illness? Because we're not staffed to meet the demand of a normal schedule, much less when humans are human and need time. So I
was gonna say, I worked in the UK for a while. I worked in the NHS, and I once had a resident from my hospital in New York come over to London, and I said, swing by the hospital and you can meet some of my trainees, right? And so I'm like, why don't you guys share your experiences as registrar residents, whatever they call them these days? And one of the UK trainees said, well, when do you get your protected time? Like your protected break. And literally the US resident went, why what? And I just let it go like 4 times back and forth. Your protected break. And she's like, what? Your protected break. I'm like, okay, guys, she doesn't get a protected break. You don't get a protected break.
I mean, so much so that one of our episodes, the Code Brown episode, was about me struggling with asphasia, like vomiting my brains out, shitting my pants, like working in the ER, getting an IV with Zofran, and still having to see patients that had a little upset stomach. I mean, it's like there aren't, to your point, Steph, like there's not those kind of protected personal times. Sometimes those are personal toilet times. I mean, like sometimes that's,
I used to take calls in the bathroom. I'd be in the bathroom and they'd be like, so-and-so's on line 1. I'm like, okay.
Yeah.
Oh, I've got a funny story about that, Lara. This was after my second child was born, and I was pumping at work, and I was trying to get a patient admitted, and the pump was going on in the background, and the surgery resident goes, "Is that the ECMO machine?" And I was like, "Yes. That is what you are hearing."
You are hearing ECMO.
It was really, really funny. Anyway, I mean, it's true though. So, not even with a protected break, but just how do we treat a resident who gets sick? How do we treat an attending who needs to call off? And then how do we talk about it? Because I will tell you, I've had coworkers who brag about rounding on a heparin drip with their PE. And it's like, we shouldn't be like nodding and smiling and going, "Oh, you're such a badass." We should be going like, "Are you okay?
What the fuck are you thinking?"
You can't win though. I remember when I was a fellow, I asked my fellowship director, just for reference, what's too sick to come to work? She said, if you cannot walk. So I showed up one night for my 11 o'clock shift, dripping with sweat from the walk from the garage into the department with a fever. And the attending who was on that evening took one look at me and said, and they were furious with me. You should have known you were too sick, but you said if I could walk, I could walk, right? So I couldn't win. I just was like.
And I will tell you, I have worked in a group where there was Jeopardy coverage for every single shift. So they would actually pay someone to be on call for a shift. If you needed to call off because you were sick, you had two responsibilities. The first responsibility was to call in with enough time so that your replacement could get there, right? So give them at least an hour before your shift. And your other responsibility was to pay them back a shift. So find a time in the next couple months when they have a shift they want to get off of, and you pay them back. And then the expectation was everybody took Jeopardy call, and if you were sick, you didn't go to work. That was very human. That was an incredibly human way of doing the work.
Exactly. So I want to kind of recap everything because we've covered a lot of ground. We've talked about, of course, the Dr. Lorna Breen Foundation, the bill, the Dr. Lorna Breen bill that is up for reauthorization. We talked about some of the great work that the foundation is doing by advocating for changes to state licensure and hospital credentialing so that the stigma starts to go away and physicians and clinicians, nurses, et cetera, feel like they are able to access healthcare services without it being a negative on their record or harming their jobs. We've talked about some of the antecedents to burnout, why burnout happens, why clinicians have more burnout than the baseline population. We've discussed a lot of those things. So Steph, just kind of as we're wrapping these up, I've got a couple of questions for you that are pretty much, I will say, as a lightning round. So
Okay, I'm ready.
we've called, medicine unstable. We've called it unstable vital. And all of us as ER doctors, we like to fix unstable things. But how would you describe the future of medicine in just a few words?
I'm hopeful because now more than ever, we're having a conversation about this issue. And let's be clear, people in the generations before us also had mental health conditions. They also had substance use disorders. They also experienced burnout. They didn't talk about it, advocate for themselves or others, or work within systems to fix that in the same way that we're seeing now. And so I'm hopeful that with continued attention, there's a better way that we will be practicing medicine, nursing, pharmacy, dentistry, right? The team sport of healthcare together in the future.
No, I love that. Laura?
We haven't talked about the one thing that I think you and I think is the most important thing, which is Noah Wiley.
Yes,
That's why I'm an ER doctor.
Like what he's done for, like he was a second year med student. We used to watch ER, we did a whole episode about how much we learned from the pit. But I think you got to meet him.
I did, and he is a lovely human. So the way that I got to meet Noah Wiley is that he partnered with FIGS to have a congressional briefing on the reauthorization of the Dr. Lorna Breen Healthcare Provider Protection Act. And him and a few of healthcare workers who are FIGS brand ambassadors spoke about the experience that healthcare workers have providing care currently and the real barriers that they face in seeking mental health care and the need. And, he's very clear he's not a healthcare worker. He plays one on TV, right? And but he hears, right. It turns out he hears from a lot of people about the importance of the mental health challenges that are being portrayed on the pit. And his mother is actually a retired nurse of many decades. And so together they came to help elevate that message with our reauthorization. Really lovely person doing a great job bringing the reality of the healthcare workplace to light in the show The Pit, for sure. It's worth noting that both the original Dr. Lorna Breen Healthcare Provider Protection Act and the reauthorization are bipartisan, right? So
Which
this
doesn't
is an
happen
area,
much today.
What's
at
that
all.
mean? Can you please
Well-
define that for me?
and this is an area where, I mean, everyone needs healthcare. Everyone recognizes that the healthcare workforce is an essential part of providing healthcare, and that there is a need to look after the healthcare workforce. So as we are working on the reauthorization, we have bipartisan support to move this reauthorization forward. And our representatives need to continue to hear the voices of healthcare workers. So please write your representative. I don't know if you all have show notes, but maybe we could throw a link in the show notes for people to write their representative and share with them why this is important for reauthorization.
Well, we are really appreciative of everything that you're doing. Where can our listeners find you? How and where? You've already told us that we can write a representative, but how can we support the foundation?
That's great. So we have individual ambassadors. So if people are interested in getting involved on a deep level, they can become an ambassador. Happy to share that link and also our website. We are philanthropically supported, and so we love donations, and that is how we continue our work and go deeper in our work. And so, advocacy, engagement, support, all of these are ways that you can support the foundation. And I always like to say, don't forget yourself in that equation, because if you're a healthcare worker, the number one thing you can do to support the healthcare workforce is to take care of yourself.
Mm-hmm. I love that.
So I think that's kind of brought us to where we're going to end today. And I think we made a big point of saying healthcare may be unstable. Our healthcare workforce is not unstable, but they need a little extra loving care, and that's exactly what you're doing. And as a fellow mom of 3 and going on the university tour this summer and juggling all the things I know you juggle, I so appreciate you taking the time to be with us today. This episode had a little more of a serious tone than many of ours do, but I think that's very appropriate. And so I just want to say thank you so much for joining us. And if you could please just give Noah my number, that would be great.
Mine too. I would take it. Yes.
Yeah, I'd really like to have him here as a guest too. So, thank you,
Well,
Steph.
thanks for the conversation. I feel like it could have gone on for hours, and I appreciate you all tackling this issue with me.
Thanks so much, Laura and Steph. And hey, this was another episode of Unstable Vitals. You can find us on where you find your podcasts, on Apple, on Spotify, on YouTube. So please continue to watch us, make comments, give us ideas for new episodes on things that are unstable in healthcare, because we'd love to talk about it. But Steph, thanks again for being on today. And Laura, thank you for being you. And it's so good to see you.
Thank you for being you, Dr. Adam.
All right. Well, have a good one. Take care, and thanks.
All right. Ciao.
Thanks for tuning in to Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit unstablevitals.com to stay in the loop. And don't forget, real change starts with real talk. See you next time.